Hello and welcome to Expert Perspectives from the 2014 Great Debates and Updates in Hematologic Malignancies meeting. So we are giving you a capsule of some of the high points of this year's meeting. Yesterday we talked about multiple myeloma with Bob Orlowski, and today we are going to talk about some of the myeloid disorders with Dr. David Steensma from the Dana-Farber Cancer Institute and Harvard School of Medicine. So David, welcome to Experts Perspectives. You did a great job moderating this morning and yesterday afternoon. And there were really some very interesting presentations. And this morning particularly, I thought was some really interesting information that we don't hear very often. We had a session which we have called Not So Benign Hematology, and Ken Bauer talked about the approach to the patient with minimal clotting abnormalities. And then I would like to go into a little more detail on your presentation regarding idiopathic cytopenias of undetermined significance or undetermined cause, because I think this is a problem that the average hem-onc doc in practice sees all the time, and how to evaluate these patients and where to go with the various diagnostic steps and what to do. Who needs just watching and observing and who needs therapeutic intervention? So give us a synopsis of what your presentation was this morning.
Sure. So I was speaking about patients who have cytopenias where there's no clear explanation, where the usual suspects have been rounded up and interrogated, and B12 and folate deficiency or iron deficiency or a medication effect, alcohol effect, copper deficiency, all those sorts of things have been excluded insofar as possible. And you're left with a patient who has low blood counts and you don't know why. You do a bone marrow and sometimes a cause is found, but often there'll be a few dysplastic cells there, not enough to make a diagnosis of myelodysplastic syndrome, and yet there's no other alternative explanation. The karyotype may come back and show you del5q or something that allows you to make the diagnosis of MDS, but usually it doesn't. It comes back normal and then you're stuck. And these patients have actually been called idiopathic cytopenias of undetermined significance, or ICUS. It is different from the USs that people may be more familiar with, like monoclonal gammopathy of undetermined significance, which is clearly a precursor state for myeloma and other clonal plasma cell disorders, or monoclonal B-cell lymphocytosis of undetermined significance, which is clearly a precursor state in some patients for CLL or other lymphoproliferative neoplasms. ICUS, these might be things that might turn into MDS. They might be immune-mediated. We just don't know, and we have to observe them over time. At least that's what we've had to do in the past. Now with some of the molecular genetic techniques that are available, we're able to find that some of these patients have clonal hematopoiesis, which puts them at a much higher risk of evolving MDS or another hematologic neoplasm. Some of them have a specific point mutation in SF3B1 or U2AF1 or ASXL1, whatever it might be, that marks them as someone who has probably a precursor state to MDS. So this is a group that we're learning more about. We don't know a lot about the natural history of these folks yet, but they're out there. And many of them are referred to me as someone who focuses on myelodysplasia by community-based hematologists, oncologists who say, you know, I have no way of knowing if this guy has MDS. Do you have any additional tests that might help sort that out?
So if you have someone like this with an idiopathic cytopenia and you've ruled out the usual criminal elements and the bone marrow is non-diagnostic, you move forward with molecular characterization and you order one of the panels of genomic studies.
Right.
If you identify an abnormality, do you treat then? Say you find DNMT3A or ASXL1. You know, do you consider this patient is on their way towards AML and treat them preemptively? or is that a patient you just watch more closely?
It's a great question. At the moment, we don't have any evidence that early treatment is superior, that early treatment staves off progression of disease. And we don't have stellar therapies for either MDS or AML. Certainly very few targeted therapies. The mutations that are most commonly seen early on are DNMT3A and TET2, neither of which we have a targeted therapy based on. So one of the challenges is, okay, now we have this piece of information, what do we do about it? I do think it is fair to tell the patient, you know, we did find this mutation. In the past, this has marked patients who had a risk of going on to developing MDS or AML or a related myeloid neoplasm. And so, you know, even though your counts may be very mild at this point, it's likely that this may progress over time, but it may be many years. And in the meantime, we're just going to watch and wait, and hopefully things will stay stable.
If you have a patient like this who is, say, relatively young, in their 40s or early 50s, would this be a candidate for an allo transplant?
That's another really interesting question. I do think these patients could potentially be candidates in the future for some sort of immunotherapy. Dick Silver, for instance, in myeloproliferative neoplasms, has studied the use of interferon very early on in patients who have a diagnosis. What about addressing before somebody has overt manifestations of myelodysplasia? That's exciting, and perhaps we'll have therapies that can preempt the disease state in the future. At the moment, the risk of allotransplant, even with, say, reduced intensity conditioning, seems much greater than that conferred by this sort of precursor state. So we're not sending anybody to transplant just because they have a mutation. But this is something that I think immunotherapy may play a role in the future.
So while we're talking about myeloid disorders, we'll jump over the clotting issues that I want to get to and talk about John DiPerzio's presentation. John is the head of hematologic malignancy at Washington University in St. Louis, and we invited John to come to the meeting and talk about his 25-year experience in managing AML, and, you know, what he's learned over those years and what he sees in the hopefully foreseeable future. And there's been a tremendous amount of work done at Washington U as far as gene sequencing in AML and related disorders. And give us a little flavor of what John and his group are doing at Washington U and what they have discovered about the clonal evolution of AML.
Yeah, so John gave really a beautiful presentation. And I think, to put this in context, at this meeting last year, one of his patients and junior colleagues, Lucas Wartman, presented about his own experience with recurrent leukemia. In his case, it was ALL, and it was found to be after he'd relapsed after a second transplant, I believe, FLT3 overexpressing, right. And he was treated with a FLT3 inhibitor, which allowed him to get into remission and have yet another transplant. And as of this moment, he's still doing well and actually doing some really nice genomics work himself at WashU. John is his physician, and John has been a key player in the genomics projects that have taken place at WashU, which have really led the way in defining what are the mutation profile, what is the mutation profile in AML, beginning with about 5 years ago now, the first AML case that had the whole genome sequenced. And now that's something that's much more tractable, much less expensive than it was 5 years ago. John talked a lot about specific mutations that have been discovered, such as DNMT3A, which is a very early mutation, a driver. He talked about some of the complexity of AML, some of the clonal architecture that is daunting. to look at. Patients with AML don't have a huge number of mutations compared to some of the solid tumors. Right. Most have between 8 and 12 coding mutations that are detectable compared to, say, ovarian cancer, where the patients may have more than 50. But despite that relative simplicity, the disease has still been, intractable in many patients. John didn't talk a lot about drugs, and that's partly because we've not had a new drug approved since idarubicin in 2002. There are some promising candidates on the horizon. We just heard a few weeks ago at the AACR meeting about IDH inhibitors, and some of the very first patients who've gone on an IDH2 inhibitor trial have had complete responses, which is exciting. One of my own patients is on that trial right now and is having a very exciting response, despite the presence of a whole bunch of other mutations, such that I wouldn't have thought he would have responded, because he also has 4 or 5 other somatic mutations. So it's really an exciting time, but as John pointed out, the key thing is to translate these discoveries into therapeutic advances and come up with novel approaches to deal with things like DNMT3A mutations that are so common.
And he talked a little bit about CARTs, and David Porter gave a very nice talk yesterday on the chimeric antigen receptor directed T cells, but John talked about CARTs, and then the bispecific antibodies like blinatumomab, and then another called DARTs, that I had not heard of. And all of these novel mechanisms for gearing up the immune system to recognize, grab hold of the malignant cells and smush them together with the T cells and lead to destruction. It's just fascinating technology, and certainly hopeful for the future.
It is. When I talk with my patients about particularly reduced intensity transplants, I point out that cancer is a failure of the immune system. It's a failure of the T cells to recognize these clones as potentially harmful and as mutated. And all of these approaches that David discussed, the work at Penn that John discussed, whether using antibodies or chimeric antigen receptor T cells, are designed to overcome that immune tolerance to cause T cell proliferation and activity against the neoplastic clone. And John, I think, is very excited about such technology because it overcomes the Darwinian ability of the cells in some cases to fairly rapidly mutate and no longer be dependent on an IDH mutation or whatever it is that's the driver. That is certainly true of antibody based therapy too. I mean, and the CAR T cell therapy. Many of the patients who have had CAR 19 cells are now relapsing with CD19 negative lymphoproliferative neoplasm. So that's these clones are stubborn.
Right. Some of these cancer cells are like the Pony Express. They change horses whenever whenever one wears out. So so it's a problem. All right. Well, let's go on, and thanks to you, we were able to convince Gene Connors to come down from Boston and talk to us about venothrombotic disorders, especially in difficult situation and especially in the malignant patient. And we all know that there is a greater tendency towards clotting associated with a lot of malignancies. Pancreatic cancer is the one that sticks out in everyone's mind, but even in the hematologic malignancies, there's an increased tendency in multiple myeloma with the IMiDs and other situations. Give us a little synopsis of what she had to say, what to do when you find an incidental clot or pulmonary embolus, who should get an IVC filter, if anybody, and what she uses as far as anticoagulation.
Yeah, so Jean talked really about 3 things. The first was, often when we are staging a patient for metastatic disease, and the example she gave was a patient with advanced melanoma, there'll be an incidental finding on a chest CT of a segmental pulmonary embolism. And in the past, the practice had been to hospitalize such patients and treat them with unfractionated heparin, and then convert them over to warfarin and have them on that long term. More recently, the practice had still been to hospitalize, but to treat more with low molecular weight heparin. And Jean presented some data that suggested such patients probably don't need to be in the hospital. They can be treated with an agent like dalteparin, which is a little bit less long-acting in case bleeding problems were to arise. And provided they're not hypoxemic or have some other comorbid condition that makes it really unsafe for them to do outpatient management, they can be treated that way.
Right.
Jean also talked quite a bit about IVC filters, and IVC filters are really overused.
She's not a big proponent.
She's not a fan, not a fan of the filters, and for good reason. I mean, most filters that go in are so-called retrievable filters. Less than 10% of them are ever retrieved, so they stay in there. They can serve as a nidus for thrombosis down the line.
And they migrate.
They migrate, yeah, they perforate. I mean, there are all kinds of complications. There is a subset of patients, for instance, who just have terrible cardiopulmonary reserve where a filter is still indicated, but many of these sort of traditional indications for a filter are no longer considered such. For instance, a patient with a brain tumor, most of those patients can be safely anticoagulated and don't need a filter. So Jean really argued for more judicious use of those filters. That's consistent with the American Board of Internal Medicine and the American Society of Hematology have come out with several of these best practices or things that patients and physicians should question. And one of them is the sort of placement of IVC filters.
Very good. We talked a little bit about iron chelation today. You had a violent argument with your co-debater, who is yourself.
Yes.
Yes. So obviously you won the debate. But give us the high points and how you use iron chelation. How big a problem is iron overload in MDS? You mentioned the free plasma iron and whether or not it's toxic to hematopoietic cells. So give us a quick synopsis of what your strong points were in that argument.
Certainly. Well, my wife does accuse me of vacillating and being indecisive sometimes, so I guess it's a fair assessment. Iron overload certainly is a problem for a subset of MDS patients, but we aren't very good at knowing who is at highest risk. And there are a lot of patients with MDS who are regularly transfusion dependent, have a high ferritin, who, yes, iron is an issue, but they really have bigger fish to fry. They have a high blast proportion, they have high risk karyotypic abnormalities, and so chelation, which generally requires a long period of time to remove iron from the body, is not really practical, especially for somebody who has a life expectancy of a year or two. That's not to minimize the potential risk of iron, and it can even potentially contribute to progression of disease if you have redox active labile plasma iron species that are causing DNA mutations to occur. So, you know, I don't believe that iron is totally benign, but I think we still aren't clear about who should be chelated. There have been several retrospective studies, and now very recently one 600 patient US registry study that have suggested chelated patients do better than those who don't get chelation. But who are you going to chelate? You're going to chelate the person who you think is going to live longer and make it worthwhile, the person who has fewer comorbidities, the person whose disease seems a little more stable, the person who can afford chelation. And so those patients are already predestined to do better. There is a prospective trial still ongoing, Telesto, accruing slowly, but is accruing, and hopefully that'll provide some further information in the years to come. For right now, it's a fairly small subset of patients that I chelate, those who I think are going to have more indolent disease, and yet they are transfusion requiring and have some other evidence besides just a high ferritin of iron overload. Some centers can measure labile plasma iron. Most centers now can measure iron concentration by MRI using T2 star or R2 star MRI, so-called Ferry scans, which can be done on liver or heart or both. Usually we start with the liver.
So it can tell you which patients are really at significant risk of serious organ damage.
Yeah, sometimes you do a scan and the radiologist will tell you there's no iron in this liver, the patient's ferritin is 6,000. Well, that's kind of reassuring.
Yeah.
You would have been. Other times the patient's ferritin is 1,500 and the radiologist says, this looks like somebody who has untreated hereditary hemochromatosis. This person has, a signal off the chart for the iron deposition in the liver. So those tests, I think, can be useful in some patients.
Very good. Well, David, thank you so much.
Thank you, Jim.
This was very good. I'm so glad you were able to join us again as our myeloid chair for this meeting, and I hope we'll see you again next year.
Sounds great.
All right, very good. Thank you. And thanks to all of you for watching this segment of Expert Perspectives. There is more to come concerning lymphoproliferative disorders, so stay with us.